The Ratify and the Quantum-R are the first two large phase 3 studies that have shown positive outcome in a FLT3 mutated patient. What is good about these two studies is that they actually target different patient populations, and these drugs don't actually compete with each other but are complementary to each other. So the Ratify study basically shows that in a newly diagnosed acute myeloid leukemia patient where you would use standard induction with 3+7 or FLAG-IDA, the addition of a FLT3 inhibitor can improve both your overall response rate as well as your overall survival. And as we recommend to most community doctors is that they should check for FLT3 mutation in their new AML patients and try to add a FLT3 inhibitor, definitely during induction consolidation, but we would suggest during induction consolidation and maintenance. One other important thing is that with the Ratify study, transplant was allowed, and the FLT3 mutated patients who got induction with midostaurin and transplant are the ones who did really the best. So we think it's really a three-pronged attack. So you want to check FLT3 for all your new AML, that's number one. You want to call that lab and try to rush it so you get the results in 7 or 8 days and can add the midostaurin. Whenever you get the results, you add it. Even if it's late, it's okay. Number two, you want to get a stem cell transplant consult early on, within the first few days of these people presenting, so that once you give them the induction and maybe one consolidation, if they're in remission, which about 70 to 80% will be, you move them very quickly to allogenic stem cell transplant, whether it's a sibling donor, matched unrelated donor, haplodonor. And the third one, which right now is emerging but is not clearly defined, is we are also recommending use of a FLT3 inhibitor post-stem cell transplant. And there are 3 phase 2 studies that have shown that if you do all these 3 interventions, you could get almost 75 to 80% long-term survival in newly diagnosed FLT3 mutated patients. And this is really dramatic because 10 years ago, when we first looked at FLT3 and the outcomes, the overall 5-year survival was 25%. So you could almost triple the survival from 25 to 75% if you do all of these interventions. So this is really, really important. The Quantum-R study now looks at a different group of patients. So these are people who got standard induction, whether it was 3+7, whether it was FLAG-IDA, whether it was decitabine, or whether it was 3+7 midostaurin. And then for some reason, either they never responded, these are called primary refractory, or they relapsed. And at the time that they were refractory or relapsed, one would say, well, what would I treat them with? And historically, we didn't have many choices, so we would just give them another cocktail of chemo, maybe using higher doses or different drugs like purine analogs or etoposide, hoping that somehow giving more chemo or a little bit different chemo will work. And actually, most of us experts have seen that it didn't. The response rates were 10, 15, 20%. You'd get much more toxicity because you were giving chemo after chemo. And so the the Quantum-R study said, well, can we look at a single agent FLT3 inhibitor in this situation? And of course, there were already 2 phase 2 studies, which were non-randomized, that showed that you could get 45 to 50% remission rates. So if that were true, then this was clearly going to be better than using more chemotherapy in these people who had already failed chemo. And indeed, that's what was shown, that when you randomize these patients and you gave them single agent quizartinib versus more chemotherapy or more hypomethylating therapy, you were getting response rates of 50% versus 20-25%, and you were getting improved overall survival, and the tolerability seemed to be better. And in the end of the day, the goal of any relapsed FLT3 mutated patient is to try to get them to stem cell transplant, because whether you use a FLT3 inhibitor, whether you use chemo, and even if you get a response rate, most of these are short-lived, even with the FLT3 inhibitors. So another endpoint, which is a secondary endpoint of the Quantum-R study, was that about 30% of patients who received quizartinib were able to make it to stem cell transplant, as compared to only 10 to 12% who received what was considered the standard of care traditional chemotherapy or hypomethylating therapy. So this is quite important, because I think this shows that you can get 3 times more people to stem cell transplant, which is the only realistic chance of a long-term cure for these patients. So we think that all relapsed AML patients should also be tested for FLT3 mutations, and if they have it, then we should consider a FLT3 inhibitor. Quizartinib is the one that was tested in Quantum-R, gilteritinib is the other one that is being tested, and I think either of these could be very, very good options in the future.
The goal of our therapy in acute myeloid leukemia remains cure for the majority of patients who are able to tolerate intensive chemotherapy. And with improvements in supportive care, improvements in allogeneic stem cell transplantation, donor availability, conditioning regimens, more and more patients are eligible for stem cell transplantation and intensive curative therapy. And so our goal really needs to be getting patients with these high-risk mutations into a durable remission such that they may be bridged to transplant or survive longer. I believe it's going to happen by the movement of second-generation, more potent inhibitors such as quizartinib, gilteritinib, and crenolinib, which are the front runners in clinical development now, into initial therapy. I think midostaurin has led the way with a type 1 first-generation drug showing some improvement in survival. I personally believe that it may be mostly due to the presence of the FLT3 mutation, but the improvement in survival was statistically significant, but not as robust as we did hope for our patients. And we're hoping to see better improvement in survival by moving these drugs up front. I think there's been some very interesting phase 1 studies looking at the combinations of second-generation drugs like crenolinib with chemotherapy, showing not only very high response rates, but compared to historical controls, with all the caveats there, the survival of patients appears to be superior when these patients are exposed to a second-generation drug.
The field, I think, is moved really forward enormously by the specific FLT3 inhibitors. We have these multi-tyrosine kinase inhibitor midostaurin now approved in Europe and US, and it will be used in patients with newly diagnosed acute myeloid leukemia and a FLT3 activating FLT3 mutation, comprising both internal tandem duplication but also tyrosine kinase domain mutation. And we already see that we will have head-to-head comparison of midostaurin compared to, for example, with the second-generation inhibitors such as gilteritinib and crenolinib in the first-line setting. So the field will move forward in that we know whether a patient will benefit more from a more specific inhibitor in the frontline setting, or whether a multi-agent or multi-tyrosine kinase inhibitor is better, comparing midostaurin, for example, with gilteritinib and crenolinib. The second point, I think, where we move rapidly forward is in that what's the best consolidation therapy? Once a patient achieves a complete remission with a specific FLT3 inhibitor, what is the best consolidation therapy? Should we go to an allogeneic transplantation for everybody? Or should we aim to have patients with a low mutant allelic ratio, for example, focusing on consolidation chemotherapy? These are clear, open questions we do not know. And finally, there is an important part in the RATIFY study, for example, covering the maintenance therapy. And this will also be done in the Quantum First study. There's also a maintenance therapy with quizartinib. And we do not know whether really a maintenance therapy is necessary to keep the patient in complete remission and to prevent relapse. And there are also for example, a new development that maybe measurable residual disease will really impact on the treatment after once achieve a complete remission. So should maintenance therapy should follow it up? We do not know so far, and therefore the results of new trials will really change the landscape of treatment with patients with acute myeloid leukemia and activating FLT3 mutations.
The hardest to treat forms of AML include, in my opinion, about 3 or 4 different groups. So one are the FLT3 ITD group, and as I said, in the new FLT3 ITD patients about 10 years ago, the 5-year survival was 25%. Today, in some of our most recent updates, both from MD Anderson, from MRC, German, and other US groups, we're getting up to 75-80% survival. So I think, in a way, the addition of FLT3 inhibitors, the appropriate use of stem cell transplant, and potentially the use of post-stem cell transplant maintenance has converted what used to be a high-risk group to actually a neutral, and maybe in the future, with the use of more potent FLT3 inhibitors, it may actually become a favorable group. So this is really quite amazing. This is where we can convert a negative prognostic factor to a neutral and to a positive one. And this is really the hope of the personalized targeted therapy, which we're seeing in the FLT3 mutated groups. Now, there are other high-risk forms of AML where we don't have a similar success story. So these include TP53 mutated AML, AML with adverse or complex cytogenetics, AML with other high-risk mutations such as ASXL1, DNMT3A, inversion 3. And for a lot of these, there's a lot of preclinical as well as early clinical research looking at new targeted agents or cytogenetically selected agents, but there's nothing really that is changing the landscape and the survival outcomes for those patients like we've seen with the FLT3 ITD. So I think this is a unique success story that the addition of FLT3 inhibitors both in frontline setting, now in relapse setting, can really dramatically improve your survival, and these patients are no longer truly high risk if we do everything appropriately for them.